Dan, the medic. Hello, a happy new year to you, and welcome to another lecture in the lecture series. Today, we are going to be talking about another cyanotic congenital heart disease known as transposition of the great vessels. So, transposition of the great vessels is defined as the anatomical reversal of the aorta and the pulmonary artery. In this case, the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. In some textbooks, the transposition of the great vessels is also known as the transposition of the great arteries. So bear that in mind. The incidence of transposition of the great vessels is estimated to be at 1 in 3,500 to 5,000 live births, with a male to female ratio of 1.5 to 3.2 ratio 1, and it accounts for approximately 20% of all cyanotic congenital heart disease cases, which makes it the second most common cyanotic congenital heart disease after tetralogy of Fallot. Now, it is important that we know the classification of transposition of great vessels. So, we have two basic types of transposition of great vessels. We have the complex one, and then we have the simple one. The complex transposition of great vessels is the one where there is additional cardiac abnormalities. Some of these cardiac abnormalities include ventricular septal defect, which is the most common associated abnormality with TGV. Then we also have left ventricular outlet obstruction, and then also there can be abnormal valves or coronary arteries. And on the other hand, the simple transposition of the great vessels is the TGV that presents with only ventriculoarterial discordance. Now, as for the etiology, the cause is usually multifactorial or unknown. There are some risk factors, like for instance, when the mother has diabetes during pregnancy, and then also the George syndrome. Now, talking about the pathophysiology. In order for us to absolutely understand the pathophysiology, we have to talk a little bit about cardiac morphogenesis. So during cardiac morphogenesis, this aorticopulmonary septum is formed, and then it normally rotates and then fuses with the ventricular septum to form the membranous interventricular septum. And this interventricular septum then closes the interventricular foramen. So when there is inability or failure of this aorticopulmonary septum to spiral, then it can lead to this transposition of the great vessels, which then results in complete isolation of the pulmonary and systemic circuits, thereby leading to decreased oxygenated blood that enters the systemic circulation. And then also, like I said earlier, ventricular septal defect is also associated with most cases of TGV. So it is due to this defect also that ventricular septal defect can occur. Now, if there is no communication between the oxygenated blood and the deoxygenated blood, unfortunately, it is fatal. It's also important to point out that this is the reason why patients with septal defects or PDA and TGV together tend to live longer than those without septal defects or PDA. Now, as for the clinical findings, of course, we are going to see cyanosis. And this cyanosis is not affected by exertion or supplemental oxygen. And then there will also be tachypnea because the body is trying to compensate for the hypoxia. And then we are going to hear single loud S2. And then in most cases, there is no murmur, but for instance, if there is concurrent ventricular septal defect, there can be systolic murmur as quoted in the left sternal border. And then there will be diminished femoral pulse. Now, as for the diagnosis, unfortunately, it's difficult to diagnose during pregnancy with fetal ultrasound, and it's only successful in approximately 40% of patients. So when the child is delivered, we can then do ultrasound. And then on doing this ultrasound, we will see that the pulmonary artery arises from the left ventricle and then the aorta arises from the right ventricle, which signifies transposition. We can also do chest X-ray. On doing chest X-ray, we are going to see egg on a string appearance of the heart. And then we are also going to see enlarged globular heart that resembles an egg lying on its side. This string that we see represents the superior mediastinum that appears narrow due to the stress-induced thymic atrophy. And then, of course, we are also going to see increased pulmonary vascular markings because the pressure coming from the left part of the heart will make the blood that goes into the pulmonary artery in this case to be a lot. So it can be dilated because of the excess blood or the excess pressure at which this blood is pumped into the pulmonary trunk. Now, MRI is rarely done. But if we do MRI, we are going to see the aorta arising from the right ventricle and the pulmonary trunk arising from the left ventricle. ECG is often normal, but typically it reveals right ventricular hypertrophy and right axis deviation. And when we do pulse oximetry, of course, we will see decreased oxygen saturation. Now, how do we treat patients with transposition of the great vessels? So the initial postnatal management is to initiate mixing between the two parallel circulations in order to ensure adequate oxygenation in the systemic circulation. So how do we do this? First of all, we give prostaglandin E1 in order to prevent closure of the patent ductus arteriosus. And also, we can do balloon atrial septostomy. So how do we do this balloon atrial septostomy? So first of all, we do right heart catheterization with the creation or enlargement of an existing atrial septal defect. So in the case of, let's say, patent foramen ovale, and then this patent foramen ovale, for instance, is not enough to cause adequate mixing of the blood, we then use this balloon to increase the size of that patent foramen ovale, or we can also cut, that's septostomy, we cut the wall of the atria in order to ensure mixing of the blood if this foramen ovale is no longer patent. And now for the main surgical repair. This repair is usually recommended within the first 2 weeks of life because delay will lead to further worsening of complications and even possible death. So the main procedure is the arterial switch procedure. And in this procedure, what we do is reversal of the aorta and pulmonary artery with insertion into the anatomically correct ventricle, as well as correction of coronary artery supply. And then also we can do the Rastelli procedure. And then this Rastelli procedure is done when there is TGV with concurrent large ventricular septal defect and left ventricular outflow tract obstruction. Now the aim of this is to create a conduit from the left ventricular outflow tract obstruction through this ventricular septal defect to the aorta, and creation of a conduit from the right ventricle to the pulmonary artery. Now as for the prognosis, unfortunately, Without treatment, 90% of patients with transposition of the great vessels will die within the first year of life. However, with treatment, long-term survival beyond 15 to 20 years of age is approximately 90%. That's the end of the video. Be sure to leave a like and subscribe if you haven't.